question is hypothyroidism. Hypothyroidism is the commonest cause of intellectual disability. So that is the preventable cause of intellectual disability. Basically, hypothyroidism will cause low IQ, but if you give the thyroid, that is protective thyroid hormone, the intellectual disability can be easily prevented. The intellectual disability can be easily prevented. So, what are the before talking about the features, you have to understand the incidence. Basically, less than 5% of the hypothyroidic babies will present the symptoms at birth, whereas less than 10% of the babies they will present the symptoms at the 1 month of the age. Okay, talking about the etiology, let us start with the etiology. So this is classification of hypothyroidism, where we will have congenital and the acquired causes. The congenital acquired causes, I will divide this into congenital and acquired. In congenital, you will have primary and secondary and peripheral. Your primary will have with respect to gland problem, whereas in secondary, it is your problem with CNS, that is your HPA axis. That is your HPA axis. This is the problem with the HPA axis. So primary again I will divide it into permanent and transient. In permanent you will have thyroid agenesis, thyroid dystogenesis, thyroid dysharmonogenesis. Thyroid agenesis, thyroid dystogenesis, thyroid dysharmonogenesis. And your transient will have maternal thyroid antibodies, your maternal antithyroid medications, and your iodine deficiency. Secondary includes central causes like hypothyroidinoma, trauma, craniopharyngioma, surgeries. The peripheral will be resistant to thyroxine, and your acquired causes, as I said, this is divided into autoimmune diseases, thyroiditis, hypothyroidism, drug-induced antithyroid drugs, and amiodarone can also be added here. Post-ablative radio treatment, radiotherapy, radioactive iodine, and thyroidectomy. After these and all, we have the classifications. We will have the thyroidism, hypothyroidism. So basically, I can divide the hypothyroidism into congenital and acquired. Your congenital will have your primary, secondary, and peripheral. Your primary will have again terminal and transient. Your permanent will have your thyroid agenesis, thyroid dystogenesis, and thyroid dysharmonogenesis. Your transient will have maternal thyroid antibody, maternal antithyroid medication, and iodine deficiency. Your secondary will have pituitary trauma, surgery, and craniopharyngioma like CNS tumor, cranial tumors, and all those things which can affect the HPA axis can be included in the secondary. Whereas peripheral can include the sensitive thyroid, and the acquired causes can also include the autoimmune diseases and thyroiditis and antithyroid drugs, post-ablative radiotherapy, radioactive iodine, and all those after the patient to undergo thyroidectomy. These are classification of the hypothyroidism. Next, we can talk about the clinical features related to the hypothyroidism. Basically, the clinical features related to hypothyroidism, I can divide the clinical features based upon some common features. What are the common features? Like delayed growth, delayed digestion, delayed puberty, delayed skeletal maturation, and constipation, and hypothermia, hypotonia, dry skin, shallow puffy face, and there will be protuberant abdomen and pallor. There will be protuberant abdomen and the pallor. This is very very important. Protuberant abdomen and pallor is present in the hypothyroidism. Whereas some features that are specific to the congenital and some specific to the acquired. So what are the conditions that are related to congenital? That is congenital is your open posterior spontaneous with delayed mentation. That is there will be low IQ and low learning ability. You will have the large tongue, macroglossia, and umbilical hernias often associated. So I can say it from head to toe. That is your delayed mentation. You will have open posterior spontaneous. You have large tongue and umbilical hernia. And talking about your acquired, you have myopathy and pseudohypertrophy of limb muscles. You will have increased celatosclerotic cerebri. So these are some of the features that are related to the hypothyroidism clinical features. Now let us talk about the investigation. So you should do thyroid function test. Basically, the routine investigation we will do, but you should check for with respect to CMTHS, CMT3 and T4, and the blood sugar. All those things you should understand. So basically, if the TSH levels are very low, T3 levels are low, then that means the problem is at secondary. Whereas if the TSH levels are very low, but T3 levels are in normal condition, then that indicates there is problem in the central process. That is central process. There is problem in the central process. There will be TSH low, and the T3 T4 level will be high. Whereas if there is a problem in the gland itself, then the results will be down. That is, the TSH levels will be normal, the T3 T4 level will be altered. So basically, you have to measure the values of T3 because that denotes your metabolically available thyroid and functionally available thyroid. MRI and CT. Next, talking about the management, you will manage it congenital and acquired. Congenital, you will give tablet L-thyroxine, 10 to 15 microgram per kg per day OD, whereas in acquired process, you will use the levothyroxine based upon the age divided dose. 3 years, before 3 years, you will give 4 to 6 microgram per kg per day. If it is 3 to 10, then you will 3 to 10 years, then you will give 3 to 5 microgram per kg per day. If it is 10 to 16 years, you will give 2 to 4 microgram per kg per day. Thank you. So this is an overall view, whatever we have discussed.